We all need sleep just like we need food, water, and oxygen. Coming up, what happens when you don't get a full 8 hours? Plus, the one major sleep problem that can have deadly consequences. Good morning. It's Thursday, February 9th. I'm Jessica Lovell, and welcome to the Morning Medical Update. Just like diet and exercise, sleep is a crucial puzzle piece in our overall health. And just like diet and exercise, many of us can stand to build some better sleep habits. So how do bad sleep habits really hurt us? And what happens when snoring crosses the line into a dangerous sleep condition? We will answer those questions and more with our guest this morning. Dr. Saurav Luthra is a sleep medicine specialist here at the University of Kansas Health System. And of course, Dr. Mark Wiley is Clinical Service Chief of Cardiovascular Medicine, also here at the health system. And Joe Davis, he is a patient who recently participated in a sleep study, which gave doctors some really valuable information about his health. This is your chance, though, to ask your sleep-related questions. So send us those via the links there on your screen, YouTube, Facebook, Twitter, and you can email the Medical News Network. So, Joe, I want to start with you. You did a sleep study here with Dr. Luthra on the advice of your doctor in Leavenworth. Why did that doctor want a sleep study ordered?
I had a surgery on my right knee. And after the surgery, in post-op, my blood pulse kept dropping down into the 40s up to 90, constantly back and forth. They recommended that I wear a heart monitor for a month, which I did. And I noticed about 8 different times that I had problems or issues. And they told me it was over 80 issues. And so I did a sleep study at home. And at that time, they told me that I had central sleep apnea, 55%. Obstructive was at 45%, so they recommended that I do an in-hospital sleep study.
So just so we all know what that feels like, what was it like when your heart rate kept dropping that made you go see a doctor in the first place?
Well, I didn't. It was one of those that I don't notice when my heart drops. The nurse noticed it in the pre-op. They had problems getting a room, so I was in post-op, I was in post-op for about 6 to 8 hours, and my pulse kept dropping back and forth, up and down, up and down, up and down for those about 8 hours.
So, Dr. Luthra, you helped diagnose Joe with what he mentioned, a central sleep apnea. That was the diagnosis. But let's back up. What is sleep apnea, and are there different degrees of it? Can you have really bad sleep apnea and sleep apnea that's not that big a deal?
Yes. So, good morning, everybody. Sleep apnea. So, Joe had a type of sleep apnea, which is central sleep apnea, but sleep apnea can be of varying degrees and varying types. And there can certainly be mild, moderate, and severe, and different implications from sleep apnea. So what Joe, we diagnosed him was a type of sleep apnea, which is really breathing rhythm instability, in which the breathing rhythm is decreasing or stopping at night, causing a drop in his oxygen and causing a fluctuation in his pulse rate and his blood pressure, and putting stress on his heart at night, which is the central sleep apnea, and that's what we try to treat him for.
So, Dr. Luthra, can snoring present as sleep apnea? What's the difference?
So this is a very common question asked. Snoring is basically noisy breathing, and noisy breathing can be benign if it is just originating from your nose and you just have a turbulence in air, it is creating some noise in breathing. That is benign, although it can cause nuisance at night for the partner. But when the snoring is also associated with a decreased airflow into the lungs, a partial or complete reduction of airflow into the lungs, and then it is also causing some changes in your oxygen levels in the blood, then it becomes a disorder, and we call it a sleep disordered breathing.
So what's the difference between central sleep apnea and obstructive sleep apnea?
So obstructive sleep apnea is the more common type. We have a large number of patients, if you look at the apnea population, will be obstructive sleep apnea. Basically, there is a mechanical obstruction at the level of the upper airway, which is at the level of your throat behind the tongue. And at that level, there is a partial or a complete reduction of airflow into the lungs. And that then leads to a drop in your oxygen. And that is what obstructive apnea is. In central apnea, you are basically either breathing shallow or not breathing at all at night. And it is not due to a mechanical obstruction. It is because the breathing impulse is getting depressed. So there is a breathing rhythm instability in central apnea, not related to any mechanical obstruction, and it comes from more physiological reasons such as heart disease, stroke, medications, etc.
All right, Dr. Wiley, you're up. So help us connect the dots here, make that heart connection. If someone has sleep apnea, how can that affect the heart?
Yeah, no, thank you, and good morning. So just as what was described, so during episodes of sleep apnea, when your oxygen levels get low, it creates a stress response, and your body essentially kicks out adrenaline and stress hormones, and those fluctuations can affect the heart rhythm at night. There's a link with atrial fibrillation. There's a link with hypertension, and just overall cardiovascular health. So all of that time that you've spent sleeping, whether it's 8 hours or maybe in your circumstance 3 or 4, I don't know how much
Exactly.
you know, your body's under stress during those times, and that does affect your heart over the long haul. So there's a clear link between sleep apnea and cardiovascular disease.
So does your heart need that break? Is just like we work out our other muscles in our body and we need to take a day off from the gym and let it rest. Is that what we're doing? Is your heart resting up for the next day while sleeping?
That's a good way to think of it. You know, you're busy all day long, and certainly that's not an unreasonable way to think about it. You certainly don't want to contribute to additional stress and strain throughout the course of the night if you have underlying cardiovascular issues such as congestive heart failure or atrial fibrillation. So that's a good way to think through.
You're welcome. See all my contributions?
I know.
Okay, so you mentioned AFib. Joe was diagnosed with AFib. He didn't necessarily feel any symptoms. Is that common? Because that could be scary if you're not feeling symptoms.
Yeah, that's common with atrial fibrillation as well. I would say a majority of patients who develop atrial fibrillation or who have it don't feel it. Some are very sensitive to it, so they know exactly when they go into it and when they go out of it. But a lot of patients don't, and there's a very strong link between sleep apnea and atrial fibrillation to the point where, you know, that's one of the first things we look at and try to address as a way to manage atrial fibrillation.
So how does somebody know if they need to come to see you or to go see a sleep doctor, or is that kind of comprehensive health care where you may have to see both?
Well, I think it's all integrated for the most part. So some of the risk factors of cardiovascular disease are also the risk factors of having obstructive sleep apnea. The AFib clinic has kind of a multidisciplinary approach that incorporates and includes evaluation for sleep apnea. So I think a lot of these things are all part of a comprehensive program.
So we're putting a QR code up on your screen. You can scan it and read more about the connection between sleep and the heart. You can also type in the website bit.ly/KU Sleep, all in caps. Again, bit.ly/KU Sleep in caps. So Joe, were you asked to wear any devices to help you breathe at night?
When the first sleep study I went, it took a procedure that they have to follow, and I didn't feel I was really going to be able to do anything because I cannot stand anything touching my face at night. They tried a number of different things up the nose, oxygen that way, and they ended up with a full face mask that covered my mouth and my nose. Also, then they tried different machines to see which one progressively would need to be done, and they ended up with an ASV machine. It took almost all night to do this, and we really, at the end of the night, it was non-conclusive. I really didn't think when I left there that I was going to be able to do this, and it did take me a while to make my second appointment to go back in. Once I went back in for the second appointment, which was about 2 months later, we knew what mask I needed, the machine and the settings, and I had the best night's sleep I had in years. I mean, I slept all night, woke up the next morning, it was fantastic.
Love to hear it. Dr. Luthra, what kind of treatments or devices do you recommend for sleep apnea? We talk about the CPAP, but have we come a long way? Are there other devices making this easier for people to sleep through the night?
Yes, absolutely. So I think what happened with Joe is a very classic picture with patients with central sleep apnea. So one thing we realized, and I told him in his first meeting, is that we cannot do an automatically adjusting machine for patients with central sleep apnea because there is a very high degree of failure rate and patients don't tolerate that. So we have to go in a stepwise manner where we conduct studies and try from simple devices to more complex devices. And on his first study night, we were only able to go from CPAP to a BiPAP machine, which is more complex, and then the night ended. And then when he came back, we were able to use the ASV device, which is specially designed to take care of the breathing rhythm instability part. And once we did that, he really responded very well to that, and his breathing was comfortable and he got a good night's sleep. So right now, in terms of treating central apnea, we have the options of trying more complex devices like BiPAP ST, which has a backup rate. We have the ASV, or the adaptive servo ventilator device. And I also now have a patient at KU that we implanted a phrenic nerve stimulator device, which means because the underlying pathology in central apnea is that you're not generating a breathing rhythm, we now have a nerve stimulator that can provide electric current, just like any other nerve stimulator, to the diaphragm, which is the muscle underlying under the lungs. And once we stimulate that, we can start a new breath, even if there is no impulse centrally for that breath. So that is called phrenic nerve stimulator, or Remedy. And that is also the latest device that we have in case that we cannot even use ASV. So there are many options for central sleep apnea. Plus, there is an option of using medications at night, and there's also an option of using supplemental oxygen. So we combine sometimes a number of these things to get the best treatment plan for our patients.
I want to show some video of a CPAP, and just so people see what that looks like. Does not look comfortable. I guess you have to lay on your back, as you can see. Dr. Luthra, do you have trouble getting patients to use it? For people who this would be their only option?
Yeah, so I'll correct a few things there. So this is not the only facial mask option. We have nasal pillows that sit under the nose comfortably. They are not full face mask in all the cases. We also have options where the hose is not coming out in the front and the hose can come out at the top. So you are able to lie down on the back or side. I have patients who sleep on their stomach using CPAP. So all those positions are allowed. We also get this initial inertia a lot where people feel that they will not sleep well with a mask on the face. But when they are getting their breathing relieved by these devices and they are getting warm, humidified air directly going into the airway, it actually feels very soothing. And I can't tell you how many times patients come back and say they felt they will not do great and now they cannot go to sleep without CPAP and they won't leave it anywhere.
Okay, so don't give it a bad name. You're saying it's come a long way. What you see or what you think of in your head, there are other options, more comfortable options
Correct.
to get people healthy and sleeping well. Okay, so we've been talking about sleep apnea, but you can get some bad night's sleep even when you're breathing fine. I want to talk about the phrase sleep hygiene. We talk about that. It's advice for getting the very best sleep, like keeping a routine sleep schedule, keep your bedroom dark and cool, separate screen time from bedtime, minimize caffeine and alcohol. Okay, I'm like, check. I don't do that. I don't do that. I don't do that. Dr. Wiley, are you guilty of any of the things on this screen?
Well, yeah, except for the keep your house cold. I try to save on my propane costs.
Yeah.
You're so thrifty. I love that. So Dr. Luthra, a lot of these seem like common sense. Of course, they're not always easy for everyone to follow them. Why is it important to practice not just one of them, but all of them at the same time? And to start, it really is a habit. You have to start practicing them, right?
I think the reason this is important is because we have a system in our brain, which is called the circadian system, or the internal clock. And what that system does is it has a particular time set for when the brain will start secreting melatonin, which is the sleep hormone inside our body. When that melatonin secretion starts, that is when we start to get drowsy, and that is the start of what we call our biological night. And then there is a time period, 7 to 8 hours after that the melatonin secretion starts to go down, which is the end of our biological night. So when we follow good sleep hygiene, essentially what we are doing is we are keeping our biological night stable. So for example, if somebody's biological night is starting from 10, ending at 6, by following good light and dark hygiene, making sure that you rest your mind 2 or 3 hours before that, don't get exposed to screens, etc., you're making sure that your night stays stable from 10 to 6. And if you do not do that, you will feel what we feel when we travel and we get a jet lag, where the biological night may be somewhere else and your actual bedtime may be somewhere else. So you're really not in sync with your own brain, and you may be lying down and not feeling sleepy, or you may be trying to stay awake in the evening but getting drowsy. So essentially you are keeping your brain's biological night stable by following good sleep hygiene every day.
Oh, okay. You don't check your phone at night?
No, never.
Never, not at all.
Kidding me? Never.
All right, so Dr. Wiley, studies have linked poor sleep habits to bad metabolic health. So what is metabolic health?
Metabolic health, I think, is a term that's really encompassing, in my mind, more lifestyle. So, I see individuals who have what we describe as a metabolic syndrome. Metabolic syndrome tends to be a constellation of things from lack of exercise to being overweight to having some labs that are more consistent with that, insulin resistance, lipid profiles, that sort of thing. So metabolic health in general, I do think is associated with things such as obesity, being overweight, and having risk factors for cardiovascular disease. All these things tie back into sleep hygiene and your sleep pattern.
All right, everyone hang tight. We're going to check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, joining us with our COVID count this morning. Hey, how are you doing? Did you make it in okay?
We need that sleep. Yeah, I made it.
Okay, good. I know. What about you? What are your do you practice good sleep hygiene?
I try to get to bed early, but the phone issue, I have to consciously make sure that I put the phone down.
Okay, sorry we text you a lot.
And I'm all the coffee during the day.
I know. It never wears off.
But I love the caffeine.
I know, you got to have it. Okay, so any change in COVID count?
Really not too much. Again, 50 total. Of that, we have 24 active. I think we had 26 or 27, so we're seeing a little vacillation, but really not much. Still in those mid-20s for active infections. 6 in the ICU, unfortunately, we're kind of up 1, and then 3 on the ventilator. I think the last few days we've had 2 on the ventilator. So a little bit of change, but still those active infections are kind of holding in that mid-20s range.
All right, so during the height of COVID-19 pandemic, there was a big gap between so-called richer and poorer countries when it came to getting vaccines, medicine, tests, you name it. Now, as we see in this headline from the journal Nature, the World Health Organization is trying to create rules that would make sure things are shared more fairly for the so-called next pandemic. It seems very vague, but what are your thoughts on that?
I mean, I think, number one, identifying and having conversations about those disparities is vitally important. We know not only countries around the world, but in communities in our country as well. And we've talked at length about the disparities that we see, not just for the pandemic, but for healthcare in general. So we need to have those conversations. We need to have those strong infrastructures of public health in those communities as well. And I think that begins here. What does it mean for the rest of the world? Certainly we know that there are countries that are less fortunate as far as resources go. It is absolutely vital to continue to try to help promote good health and healthy areas for those countries as well, because we know everything is just one plane flight away, and we are only as strong as our weakest link. So these conversations need to be had. How much is the World Health Organization going to have teeth for this? That remains to be seen, but we need to have those conversations. Assessments need to be made. There should be solutions or coming to solutions, really to help all of the people, especially in those resource less fortunate countries. It's a very good thing that this came out. How much will it affect on the ground? That's hard to say, but those conversations need to keep being had, and we need to keep striving for that equity and equality for all sorts of things, including healthcare as well.
Doc Hawk, thank you for that. What we learn about sleep relies on, of course, sleep studies. It usually involves going to a clinic and sleeping with some devices strapped onto you so that they can learn what's going on while you sleep. Joe, you went through one of these sleep studies, so tell us what it was like. What did it feel like?
The first one was trying to get the correct machines and the correct mask. Once we found the mask and the correct machine, it was fine. In fact, I worn it every night from August until last night, even last night.
And you're feeling better? Your health overall?
Very much so. I can sleep on either side or on my back. I prefer my sides. And even the machine that you showed the picture of the gentleman that had the full face mask, I have one that looked like me. And I can still sleep on my side. I can roll over. I've had both knees replaced. I've had both hips replaced. I have to sleep with a pillow between my legs. So it's not a comfortable. It wasn't in the beginning, but it's much more comfortable now, and I can sleep much, much better.
Great. I'm glad that they got you adjusted to what was working well for you. Dr. Luthra, sleep study devices could also be shipped to your home. I want to ask, how reliable are those home tests, or are overnight sleep tests just better?
I think home tests are getting better and better, and right now the technology we have is pretty reliable. I like to think of home sleep apnea test as a rule-in test, a screening test. So if anybody you are suspected to have abnormal breathing at night, it is very convenient to do these tests. They can be shipped to your home. They can be picked up from the sleep lab, and then you can wear it very easily at home and get good results. Now, there may be some cases where somebody has a lot of symptoms of apnea and their result is borderline or negative. In that case, we always have the option to bring them into the sleep lab, but a vast majority of patients can get diagnosed based on these home sleep apnea tests.
Dr. Luthra, I did one of those sleep studies probably 20 years ago, and it was like everything, they had wires, and I was all taped up. This is when I was in TV news and would get up at 2 a.m. every day, so they were trying to find if I was getting good sleep. I could have told them no, I was not. But it was, tell me what it's like during it. Do you really like have like a room set up, like a bedroom? I remember it was supposed to look like my bedroom, but I was all taped up, and people would come in the middle of the night, and I knew people were watching me and monitoring me, so of course I was waking up all the time. But what's it like now? What do those rooms look like now?
I think they look like, I mean, we try to make sure, and different labs can have different arrangements, but the goal is to make a comfortable sleeping space that looks like your bedroom. It has a proper bed, a proper mattress, pillows, etc. And then you are having leads on your body, but the entire way of putting those leads have become more organized. So we try to organize the EEG leads that come on the brain. We try to use things that don't stick to your hair much after you're done with the test. So they have improved those techniques, but it still involves putting leads, because we do need all that information. We're trying to gain all the information from your brain, from your limb movements, from your airflow, and from your oxygen numbers. But I would say that when I am reading these sleep studies, 95% of these sleep studies, I see patients within 30 minutes are going into sleep, and then they are more or less following their natural sleep pattern that they get at home. It is always an initial part where they may struggle getting into sleep, but once you are into sleep, I see a lot of natural pattern that I would expect that they are doing at home also.
I did fall asleep, Dr. Luthra, I promise. And I know they've changed a bunch, but it was interesting. It was interesting to be a part of a study like that, where they were actually getting reads and good information to share the next day with me. So it was really fun. I did a story on it. So it was cool. And Dr. Wiley, the findings that come out of these type of sleep studies, how does that impact the work you do in cardiac care?
Yeah, a good question. So whenever we have patients that we're trying to manage, whether it's hypertension or atrial fibrillation, and we obtain a sleep study, those results are very helpful, because if we do identify sleep apnea, for us, it's an opportunity to address a problem instead of add another medication. So when I look at a sleep study, it's the frequency, how severe. There's a correlation to the severity of the sleep apnea, to the benefit that they're going to get when the device is on from a management standpoint. So it's nice to be able to identify a problem that Dr. Luthra can address, and we can improve quality of life and not add another medication. So I typically, I wouldn't say I get excited about abnormal sleep studies, but I do when I'm trying to manage a patient in this way.
It tells you a lot.
Right.
What'd your wife tell you today when you were driving in today, and she asked you what you're going to be talking about?
I told her I was going to be talking about sleep apnea, and she apparently I might have it. So Dr. Luthra, I'll probably be connecting with you at some point, because I've asked her for documentation about snoring. I've never seen any proof.
People say I snore. People say I don't believe them.
No, I gotta see it on a phone or video or something.
They
but
have
I
it all
haven't
wrong.
Yet. Right. They got it wrong.
Okay. He's calling you, Dr. Luthra. That's his wife's
I'd like to
orders.
add here that when you have a heart disease and you have central sleep apnea, you may not snore. So think about that. You may not have snoring when you have a lot of central apnea. So sometimes your only hints are not feeling rested. If your sleep is not restful, you're spending 7-8 hours in bed, waking up a lot at night, feeling still like you're not feeling fully alert and focused, there may not be full restorative sleep going on. And that would be the only hint in some cases.
Great to know. Very important, Dr. Luthra. Thank you. Do we have any reporters on the line today? Let's get to our viewer questions. And I do have one. Can poor sleep lead to high blood pressure?
Yes, I would say that poor sleep patterns can certainly lead to high blood pressure or complicate the management of high blood pressure. There tends to be a correlation with sleep apnea in these episodes, and that tone overnight where the body's adrenaline kicks in and stress hormones are released in the setting of obstructive sleep apnea does make management of hypertension more difficult. So,
Dr. Luthra, is there any update on the Philips ventilator recall associated with CPAP machines? This was a couple years ago.
Yeah, the most recent update from Philips was that they initially went with this recall, and that was all done 2 years ago. But then they conducted extensive studies more in Europe than US, where they actually looked at all these devices. They examined the foam inside it, and they conducted more scientific analysis. And the preliminary data from that is that mostly their devices do not have any foam disintegration. They have not figured out any strong correlation between foam particles disintegrating and causing any serious health harms. The only positive finding they got that patients who used SoClean as a cleaning system for their CPAP that uses ozone, those devices had a higher degree of disintegrated foam inside them when they examined those devices. But does that disintegrated foam really lead to health disease? They were not able to find a correlation. So they are now in the process of submitting all this data back to the central agencies, federal agencies, to see if the recall gets any change. For now, the recall stays in place, but the data has not been convincing of any real problem to health because of these devices.
Frank wants to know, does it matter when I get my 8 hours? He has kind of a wonky work shift. What does that tell us?
I think it does not matter as long as his brain's biological night, which I mentioned earlier, is also in those 8 hours. For example, if my brain wants to sleep tonight and I lie down in the morning for 8 hours, I'll have a very choppy, unrestful sleep because I was not in sync with my internal rhythms. But if you get in a routine, let's say you are a night shift worker, and you do things which are advisable, and then your sleep night actually gets shifted during the day. So every morning you're sleeping during day, waking up at a particular time, and your brain has adapted to that, then you can continue to have a restful sleep, doesn't matter when you get it. But if you fluctuate and you have one night shift, one afternoon shift, one day shift, you will be all over, and your rhythms will not be in sync with when you're lying down.
So consistency is key.
Correct.
Erica wants to know, what's the best sleep position, side, back, or belly?
Sides, in patients who have any sort of airway obstruction, side sleep tends to be always better than the back sleep. Stomach sleep is somewhere between side and back. I would say the best is side, but it also depends upon your shoulder issues, your musculoskeletal issues. If you don't have any airway obstruction, let's say you are an individual with a proper facial structure, proper BMI, you don't have any apnea, it doesn't matter how you sleep.
What about for the heart? Is there any better way to sleep that, like, the heart likes us sleeping on our back? Does our heart like us? Does it care?
I don't
it
think
can push
it
on
cares.
through?
I think it can. Yeah, it's resilient. It's
Okay.
very resilient. So
Yeah.
there's no preference on that.
Just get sleep.
Just get sleep.
Just get it. Okay, let's talk melatonin. Give us the good, bad, and the ugly.
So melatonin is very commonly used over-the-counter medication. I think the bad thing I see about it is sometimes patients are taking too much. Sometimes I get these reports where patients are taking 10, 20, 40 milligrams of melatonin, which is supraphysiological. As long as you are taking somewhere between 1 to up to maybe 5 or 6 milligrams, and you are timing it properly with your bedtime, and it can help get you more deep sleep. But do not take excess of it. What may happen is if you take excess, you may feel excessive grogginess after waking up. And that may be actually coming from melatonin. But otherwise, when timed properly, used in a proper dose, I think it's a great tool over the counter for bad sleep.
Jean wants to know, what's the best way to minimize jet lag?
So the best way to minimize jet lag depends upon how far you are traveling. And if you know in advance you're going to travel so many hours, you can expect your rhythms to be shifting by those many hours. What you can do is time your sleep accordingly, which means, let's say you're going to a place where the timing is going to be earlier than where you are. So your brain will be get ready to sleep early. So then maybe, a few days or a week in advance, you can slowly try to shift your bedtime earlier and earlier. So when you land at that place, you are more in sync with where your internal rhythms are going to be. So that is one way. The other way is, let's say that is too complicated, you don't want to do that. When you land, you just try to follow good light and dark hygiene, which means after landing, if it is bright, try not to sleep then. Before going to bed, you can take a small dose of melatonin, and then you may take 1 or 2 days, but your rhythms will align to the new place that you're at.
Couple more questions. Kathy wants to know, can you have both obstructive and central apnea?
Yes. And actually, in majority of the cases, you will have some degree of both. But when we call somebody that they have central sleep apnea, what we mean is that more than 50% of their events are central in nature and less than 50% are obstructive in nature, but they commonly coexist. They happen in the same patient at the same time.
Emily wants to know, if someone's doing all the right sleeping hygiene, all of it, they're doing all the stuff, but they still can't sleep, should they try medication? When should we know to come see you? What are the big signs that we should come see you? What should we try first?
So I'm not a proponent of trying a medication before understanding why somebody is not sleeping, because we see this very commonly. When patients come to us, they've already tried several medications. But there are so many factors that can lead to bad sleep. There can be stress, there can be excessive mind racing, there can be excessive leg movements at night, there can be sleep apnea. So there are so many reasons, or there can be a circadian mismatch, delayed phase, advanced phase, etc. So I think if you are not sleeping well and it has been more than 2 weeks, and that poor sleep is leading to a dysfunction in your daytime lifestyle, that is the time to talk to your physician about poor sleep and really go into depth of what caused it, how often you have not slept well, what is going on with your mind when you're lying down, etc. And that questionnaire should be done before starting on any medication. And if you have not slept well for more than 3 months, and you have already talked to your family physician and things have not improved, at that point you should see a sleep physician like me.
All right, I take that back. I have 2 quick questions. What's considered a reasonable amount of melatonin to take at night?
Anywhere from 1 milligram to up to 5 or 6 milligrams is a reasonable amount. I think anything over 6 can cause more grogginess in the daytime.
What about for kids? Melatonin for kids okay?
For kids, you can give them anywhere from 1 to 2 milligrams. 2 would be the max for kids, I think.
Okay, Kathy is getting the last question. She cares for her elderly mom with sleep apnea, but she is up every couple of hours of the night, which means Kathy is up every couple hours of the night. It's concerning her because she feels like if she's only getting a couple of hours of sleep at a time, even if she's getting 8 hours, but it's being interrupted, she feels like this might affect her health. True?
Yeah. Yes. Especially if patients are waking up with using CPAP, then I think we should study a little bit more exactly what is going on. Sometimes the settings may not be correct. Sometimes the mask may be leaking, or sometimes they may have a different problem, such as the bladder issues that may be waking them up. But waking up multiple times at night is not good for brain health.
All right, so she's got to try to figure that out. All right, I want to get to final thoughts. This is always such a great, anytime we talk about sleep, everybody chimes in because it affects all of us, right? So I want to start with Joe. And Joe, thank you so much for just sharing your experience and how you came to find better sleep. Any final thoughts? What do you want us to know?
If in doubt, do it. I was very reluctant to see if I could find something, and once I did, like he said, I sleep every night with it. I feel like I'd get much better sleep. I have no problem driving 6-8 hours a day when I go to visit my daughter without even feeling drowsy. For me, it's really helped.
It's a lifestyle change.
Yes.
Living a better life.
Yes, most definitely.
Joe, thank you so much. Sleep well, my friend.
Thank you.
Dr. Wiley,
Thank you,
final
Joe.
thoughts?
So great conversation, and Dr. Luther, thanks for the information today. I would say final thoughts from my end. If you're being managed for hypertension or atrial fibrillation, a sleep evaluation should be part of the workup and potential management. So I would say that it's probably underutilized. So definitely proceed if there's a question.
All right, and you get good sleep too, okay?
Yeah,
We need
thanks.
you. We need you.
Yeah, thank you.
Dr. Luthra, final thoughts.
Well, I think my final thoughts are, don't think of sleep as a lifestyle issue only. It definitely causes snoring and daytime sleepiness, but sleep is very fundamental to your normal functioning of brain, normal functioning of heart, normal functioning of your immune function, especially important with COVID and other pandemics, normal functioning of your endocrine system. Sleep apnea can be related with hypertension, like Dr. Valley was saying, heart disease, stroke, dementia, etc. So think of sleep just like you think of high blood pressure or diabetes. It's a chronic medical condition, may not be very symptomatic, but we treat it for long-term better health.
Thank you so much. Dr. Luthra, always good to have you on and have your insight. Dr. Hawkinson, final thoughts.
Yeah, sleep is so important. Again, a great topic today. Would second that point that Dr. Luther made. Before we had vaccines and antivirals, we heard about, what can we do to help our immune function, specifically for COVID, but also in general for immune function. I think one of the main things that Dr. Stites and I were talking about was getting good sleep, adequate sleep. Of course, that also goes with activity and healthy nutrition. People are always looking for medications to help with that immune function. Really, those few things are what you can do to help with sleep. I think everybody should get evaluated for sleep apnea for sure. What I really hate though is those sleep jerks that occur right before you fall asleep.
Oh,
those
yeah.
Hypnic twitches that occur.
What is that? Dr. Luthra, what is that? That weird twitching?
That's basically mean, so hypnic jerks are a sign of sleep deprivation. It basically means that your brain wants to fall asleep, but your cortical mind, your mind that is thinking, is not ready. So you have two contrasting systems in your brain, one trying to make you sleep, the other trying to wake you up. So you are drifting into sleep and then you are waking up with a jerk. So that is what it means, a sign of sleep deprivation.
You just solved like one of the world's
Yeah.
biggest mysteries.
That's why I think 70% of the population has it. Although I don't know that Dr.
Yeah.
Stites has, because I don't think he sleeps.
He
And
doesn't
if he
sleep,
does,
but
it's
he does
always
that.
with one eye open.
He should, but he has sleep apnea. He talks about that all the time. He has to wear that CPAP. But oh my gosh, the jerking.
Yeah.
Yeah.
Has that happened to you?
Yeah.
It has.
It has.
Yeah.
Okay, so okay, we figured it out.
There you go.
This whole show, we
What an
figured out
expert.
the
Thank you.
big mystery. Dr.
Hypnic
Luthra.
jerks, yes.
Thank you so much. All right. All Things Heart is coming up at 10 a.m. Host Alexis Del Cid is joining us now with a preview and a slight spoiler alert, Alexis. This is a must-see episode, a fantastic story that you have been working on. Okay, tell us about it.
It's such a good story. If there ever was a great time and a great place to go into cardiac arrest, as strange as that sounds to say it that way, this would be it. You're not going to believe who just happened to be passing by when this man collapsed during his evening run.
If you could script who miraculously would accidentally show up on the night you had cardiac arrest unexpectedly, you couldn't have drawn it up any better.
A life-threatening event and a life saved, and it was saved in the most unexpected way. Watch All Things Heart this morning at 10 a.m. and bring your questions. And Jess, I got to know, is there a name for that sleep jerking thing that happens to me every single night?
All right,
What's
Dr.
it called?
Luthra. Dr. Luthra, we got to bring you back in. Does it have a name, or is it just the weird jerking thing?
Hypnic jerk.
Hypnic
HY.
jerk?
Hypnic jerk.
Correct.
It sounds like a dance move. Okay. The hypnic jerk.
Could be.
Okay.
Oh, that's so
I love
weird.
that.
I always wondered about that.
I always thought I was like the only weird one. And you always
No.
feel really weird after you do it. You're like, okay, that
Yes.
was weird. Or you wonder what you
Like
looked
you're-
like.
Like you're falling off a cliff or something. It's
Yes.
the weirdest feeling.
Yes. Okay. Now we all know. I mean, it's not going to stop happening, but we at least know
Right.
what it is. All right, Alexis, thanks so much. As you know, and everyone else, we're counting down the days until the Super Bowl. The Chiefs play in about 80 hours, but who is counting? The University of Kansas Health System is caring for the kingdom. Take a look at this. New photos straight from our NICU. Some of our littlest Chiefs fans all dressed up and ready to go. This is the Ewert twins. Oh my gosh, cheerleader and quarterback. future Chiefs fans, about 1 week old. We'll have more of these NICU photos for you tomorrow. I mean, cute babies. You can't get better than that. And while we wait for the big game, check out the KU Sports Medicine Twitter feed at KU Sports Medicine. Dr. Paul Schreppel is sharing some of his great health tips, advice he gives to both Chiefs players and all of us everyday so-called sort of athletes. So he's the guy. So check this out at KU Sports Medicine. And thank all of you for watching us today. Hope you learned a lot. Enjoy your day, get a good night's sleep, and we will see you back here tomorrow. Coming up tomorrow on the Morning Medical Update, an officer survived a gunshot to his head. The next step, rebuilding his face. I'm Jessica Lovell on the next Morning Medical Update. Hear from that officer, plus where doctors found the bones that put his face back together. That's Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.